So I'm going to introduce our next two speakers, Dr. Stephen Fawcett and Dr. Vicki Colliacres. They're both from the University of Kansas Center for Community Health and Development. I'll introduce them both right now, and then they're going to tag team this presentation. So first I'll introduce Dr. Vicki Colliacres. She's Associate Research Professor and Associate Director at the Center for Community Health and Development. Oh, there she is. Wave your hand. There you go. She's up there. She serves as an investigator on several projects promoting health equity in Kansas City metropolitan area, and she directs several evaluation projects that support partners who are working to promote health through their comprehensive initiatives. The first speaker that's going to lead us off is Dr. Stephen Fawcett, and he's the senior advisor at the same Center for Community Health and Development and co-director of the World Health Organization Collaborating Center for Community Health and Development. Like I said, they're both located in Lawrence at the University of Kansas. Dr. Fawcett has been a scholar in residence at the Institute of Medicine at the National Academy of Sciences and a member of the IOM Board on Population Health and Public Health Practice. He has consulted with the Robert Wood Johnson Foundation, the Centers for Disease Control and Prevention, and the World Health Organization, especially in their regional offices for Africa and the Americans. He's also a visiting scholar at the World Health Organization in Geneva and a member of the WHO Expert Panel on Health Promotion. Very impressive. Welcome, Dr. Fawcett.
Thank you. This anticipatory applause, of course, adds pressure for any communication. I think that there are two sources of humility in my adult life. One is parenting. Any parents out here can fully identify. And the second is trying to understand how it is that comprehensive community health initiatives work. Very humbling, very humbling. Some years ago, I had the privilege of being on a panel for Institute of Medicine, National Academy, on evaluating obesity prevention efforts and studying the work of a lot of people in this room and trying to distill the experience that you bring to this work. And the group commiserated on, first of all, acknowledged we know some things. We know that if we're going to make improvements in population-level outcomes, such as childhood obesity, that we need to affect the behavior of large numbers of people. Not only children, but those who affect the environments in which children find themselves, right? All the environments in which they find themselves. We know that. We also know that to do that, we better change an awful lot of environments at multiple levels. I know that's a theme here. Multiple ecological levels, and we probably need to target behaviors quite directly and clearly and specifically, probably. And that's about where our understandings and agreements stopped when it comes to comprehensive community interventions, because where we get stuck is understanding the dose. Those, such as economists and others, who've showed who've been engaged in community health improvement efforts related to childhood obesity, where they've shown effects, have done a great job of measuring the effects and seeing and establishing the effects occurred and the conditions under which they occurred. What we don't know very well is what that dose is that it takes to achieve such outcomes. We heard earlier from some of our colleagues, including our colleague from Washington University, speak about dose-response relationships in an individual and a family context, where it's easier to track and understand and trace what might be easier to track what might be the dose that's associated with the response of interest, in this case, lower childhood BMI. What we struggle with at a community level is how to capture what's going on, those community programs and policies and environmental changes that are occurring in all those settings and contexts that child makes their way through. And so our hunch is that the amount of those changes matters. And so this Institute of Medicine panel was saying, gee, really, that's important. But we also know that not all like not all children are alike, not all settings, not all communities are alike, so are not all community programs and policies are alike. Some of them presumably are more intense than others. They have more strength of change strategy, et cetera. But we don't know how to measure that very well. We don't know how to weight them in a way that we can do so reliably. And further, if we could do so, and here's what was the hope, if we could figure out the intensity of community programs and policies while they were occurring and could feed that information back to community initiatives, like some of the ones we were just hearing about, then wouldn't it be great? Because then we could give a sense of, maybe begin over time, not yet, but begin to project what kind of outcomes we might get if we continue to produce changes in the environment of the sort that we're being there, maybe with a range, maybe with a window that suggests what we might actually achieve if we continued in this fashion. So that's why this study, because we know little about that, and our colleagues at NIH were interested in figuring out how this might work. What works, and what would work to achieve improvements in BMI among children, and what are the conditions under which that might work. So that's how this, and why this study was born. It was a big study. 3,000 children in 130 US communities. And these were communities in which some things, it turns out, were happening related to promoting physical activity and healthy nutrition as it related to children. But not all these communities were doing anything that would regard themselves as being engaged in a childhood obesity intervention. Rather, there were things happening. So we wanted to in this study, take a deeper look at what was going on in relation to this. And here were the aims of the study. It's the first one that Vicki and I will focus on in this conversation. And that's the associations. What we're interested in is identifying any associations there might be between characteristics of community programs and policies and BMI, diet, and physical activity among children. We're looking at other things too, mediating variables related to the community, family, and child factors and other things as well, and some other more specific aspects. The one we'll focus on especially is what we were learning and what we think may be important about arranging conditions related to community programs and policies as it might affect outcomes for children. So this was an observational study, and that is, no interventions were planned or designed by folks. It was a look at what was happening in communities. That's the period in which it occurred. It also involved a 10-year retrospective component. More about that in a minute. As I said, 130 communities. That was defined as high school catchment area. Engaged over 3,000 children, and from whom BMIs were collected. Without getting into the design in great detail, the emphasis that we'll talk about in this context is really a retrospective piece that went back 10 years and looked at the pattern of community programs and policies that we were observing in communities over time, and their intensity and the association that had with BMIs. So lots of people involved in this, lots of partners, big study. Battelle was the prime on this. Our team at the University of Kansas that Vicki Colley-Akers, you heard for a minute, led, had the community measurement piece. We've been doing this work very locally. You'll hear from Monica Mendez a little later today, this afternoon. And Vicki will talk a little bit about some of the work with Latino Health for All Coalition. Some of the early work in measuring intensity was done and refined very locally. And we were snagged for that role. Our colleagues at Berkeley, including Lorene Ritchie and others, colleagues at South Carolina related to physical activity piece, Russ Pate and others, and a bunch of scientific partners and others who were helping frame the study. In addition, there were two protocols, a standard one, which everybody got, and an enhanced one that some children and families experienced. Essentially, for the purposes of this conversation, we looked at BMI. And this was probably the key part of the study, was obtaining consent for what we referred to as abstraction from the child's medical record of BMI at time earlier and time gathered now. There are many other things that were gathered, nutrition questions, et cetera, and the enhanced protocol involved some other observational measures of the sort that I know you've referenced and are familiar with. So why bother? What is known is that communities are engaged in this work. Communities are going about changing programs and policies and environmental features as it relates to physical activity and healthy nutrition. That's happening. We assumed it was happening to varying degrees, and we assumed it was happening in different ways. But the knowledge base for a broad, diverse sample of US communities, in this case 130, about what was going on, not so much. So we were trying to address that knowledge gap and also trying to figure out how to measure dose, and to do so in a way that would help us consider whether the dose of what we're calling intensity of community programs and policies, and a proxy for dose, was associated with, and under what conditions was it associated with diet, physical activity, and healthy weight. So we had a protocol that we used and a focus. As I said, we were focusing on programs, policies, and environmental changes. Not shocking, given all the work that we do and our intent, right, to change the environmental features. And we developed a protocol that was based on work we've been doing for the last 20 years or so in community measurement, measuring community programs and policies related to this, upgraded, I think, and enhanced and refined with some of the work very locally with the Latino Health for All Coalition and measuring intensity. But essentially, it's got 4 elements. First, capture. And in this retrospective study, this was a particular challenge. So key informant interviews, document abstraction was used with key informants from different sectors in which you hope and expect there might be changes going on. Schools, for example. And this capture piece was intended to gather information, narrative information, about what was occurring and the timing of that occurrence. We then coded that to differentiate community programs and policies that actually occurred from plans people had, from thoughts and wishes and hopes and times they got together and commiserated about the challenges they were facing, all those things that also happen when people are doing the work, but are not changes in the environment. Thirdly, we sought to characterize these in ways that would help us measure intensity, but also help us analyze and address other questions. More about that in a second. And we then sought to calculate intensity scores that would give us a single metric that we could use to then look at associations. So that's essentially what we did. The characterizing piece was really interesting. You imagine the size of that group and all the things they were interested in, right? We had to try to distill a practical protocol for characterizing what turned out to be over 10,000 documented community programs and policies in 130 communities. A lot of work, enormous amount of work. Vicki's team led this work. But as a scientific community and scientific partners, we centered on 3 attributes to go into the intensity score. That is the measuring of the weighting of these community programs and policies that we were seeing. One was duration. It made sense that things were around for a while would allow for exposure, right? It also made sense that reach was important. Those things that involve relatively few people versus those environmental changes that might be open to which many more could be exposed. And behavioral intervention strategy became our proxy for strength of evidence of effectiveness, right? Whereas providing information is the most prevalent and the most innocuous and relatively weak intervention we could possibly put in place relative to environmental change, policy change, and the like. We also looked at other attributes: primary goal, behavioral objective addressed, sector in which implemented, et cetera, and these allowed us to characterize things further and to analyze some other questions of interest. So long story short, we took this, or short story long. So in essence, we then took this and created an intensity score for each of the 10,000 plus community programs and policies. Imagine the size of this database. And long story short, we used this formula to construct it. What's more important probably for our purposes is the example. Oops, sorry. Here's an example. So to contrast these, and here's how we arrived at a score for two distinct pieces, right? Again, one's the highest. So creating a walking path, greenway, the connecting neighborhoods and schools in the context of the goal related to physical activity would be characterized that way. Perceived to have a high duration, to be ongoing, a higher reach, estimated to reach a good portion of the population, and using a stronger form of behavior change strategy. By contrast, an educational seminar with relatively few people, et cetera, was given a lower score. So these were then used to compute, if you would, weighted community programs and policies that had been captured. So what this displays is the distribution we observed. And this is the unweighted set, the non-intensity set, just directly observed, and what we observed over time. A couple highlights. One thing we should know, the mean line reflects, and this is all remember this is retrospective, so there was the study years that began in about 2006, and then retrospective, and then continued, right? So this is the look over the entire study period. And a couple of things really pop up, right? Some communities are making a heck of an investment and environmental changes that relate to their efforts. And some communities, not so much. Wide differences, enormous variability there. And so think of these as lower and higher investment communities. So naturalistically, this is what we were seeing. Similarly, if we set a similar picture when we weight them, right? And we look at intensity scores and we see similar kinds of patterns. Some with much higher intensity, if you would, of efforts, and others much lower. And with this sort of mean path. We also saw some increase over time. That was statistically significant difference over time. Of course, this could reflect more recency and recall, and that's can't rule that out in a naturalistic study like this. So some takeaway messages. Here's a few. Clearly, some communities are investing a whole lot more than others. And there's a wide range, both in the number and the intensity of such programs. And this, we observed an increase over time. Now, what might be associated with this is the whole array of things that people in this room, I know, have been contributing to through their experience, through their work, through their testimony, through their investments. That is, going back to the series of studies coming out of the Institute of Medicine of the National Academy that really were calling attention to this issue, which led to a pattern of investment, not only by governmental agencies like CDC, but also foundations, like the local ones that were investing in some of the local work to attend to this, right? And so this, no doubt, led to collaborative action, which in turn has been associated with what we observe to be changes in the amount and intensity of programs over time. And that's a nice, one could literally overlay the array of studies and the associated investments that led to these changes in the environment. And that, to me, is encouraging, very encouraging, that one can set an agenda, invest in it, and see environments changing in a representative sample of a diverse sample, at least, of communities nationally. So remember, we characterized other things as well. And one of the things we characterized, another one is behavioral objectives. So here's the premise, that to move, to have an impact on healthy nutrition, for example, there are an awful lot of behaviors that are involved, and some of the earlier studies commented on these. So our respective teams, the Berkeley team, that Pat Crawford and Lorraine Ritchie and others were leading, and with consults from this broader group of scientific advisors, identified a set of behavioral objectives that might well be influenced by environmental changes of the kind we anticipated seeing. And you can see some of them here. And you also notice that more of them were targeted to increasing fruits and vegetables, some to high calorie snacks, et cetera, and fewer relation to sugary beverages, et cetera. One could see this changing over time, couldn't you? If Jim Krieger and the other folks that are working on trying to really wage war on big sugar, we may see some differences in this in terms of patterns of investment and change that are occurring. We'll see. And so we observed some marked differences in what we were seeing, but also some distribution of the engagement in terms of targeting multiple behaviors related to the construct of interest, in this case, healthy nutrition. So a few takeaway messages from this with respect to nutrition. What we observed was that longer multiple years of exposure is better than shorter. This was one of the findings that Lorene and Karen Webb and others identified, our partners in this, nutrition partners. That several features are more important than a single one. Not a shock to anybody here. And yet, though, most of our research also typically tests a single thing, right? To be able to show that cause and effect relationship that we so revere, right? High on internal validity showing cause and effect, not so much like what we see in the world. And that more effort needs to change some behaviors, eating in fast food restaurants, et cetera, perhaps. And that physical activity may be associated with improved nutrition. More on that, you could read the studies that will be coming out in the fall. And considerable room for changing environments related to this. Lots of work to be done. Not news to anyone here. Here's a parallel set of considerations for physical activity. Russ Pate and the team, drawing on the work of Jim Salas and many others, really sought to identify classes of physical activity behaviors that might reasonably be moved by the kind of environmental changes that we anticipated seeing. And here you see just far and away increasing community participation in physical activity, after-school programs, and home and family physical activity were targeted more often as we were able to categorize these as we were able to characterize the community programs and policies related to the goal that we saw. And much fewer for some others, walking to and from school, et cetera. And so we might see some of these, of course, are more expensive, more challenging, right, investments. And we may also see, but all of these are increasing a bit over time. Again, the recall bias may be playing out here. But we might see, as we see investments in particular kinds of things that begin to show particular effects, we might see corresponding increases in communities across the country. We'll see. So some observations from our physical activity partners in their deeper analyses. Longer 6-year history of exposure was more to behavior change strategies was associated with children's moderate to vigorous physical activity. That's both encouraging and challenging, right? Because it means what we produce today may not have the effect that we intend without exposure over a long period. Better get busy. Not that we're not, right? And that community initiatives may be more successful if they're sustained for a while and they employ multiple behavior change strategies. More on this in a second. So the last point I'll make, and I'll hand it off to my colleague, and this is an analysis that Ed Frangio from South Carolina, another investigator in this team, led. And this is, we think, really interesting. This scatter plot shows the relationship between BMI on the y-axis right here, higher BMI, lower BMI in children, association between what we're referring to as the community program policy target behavior score, right? What the association we saw, and this was significant, is that the more different target behaviors sought within nutrition, we were looking at that a moment ago, the lower the BMI in children. The more different target behaviors are targeted within physical activity, the lower the BMI score. Now, this just adds to the challenge of the work, right? And the necessity for not just picking a single class of thing, undifferentiated class called physical activity, health, and nutrition, as people in the room know, but at a community level as well. And this becomes perhaps one of the things that we would be providing feedback on in a perspective study. So my last comments, takeaway lessons from this. Community showed great variation, number of types of change objectives addressed, behavior change objectives, and that we need to pay attention to the comprehensiveness of targeting. And indeed, we may feed back to collaboratives that are going forward information about the proportion of investment for different kinds of very concrete behaviors associated with the classes of interest, whether that's physical activity or healthy nutrition. So with that, hey.